But an MRI is not only showing the fracture, it is also showing the extent of fracture, the anatomy of fracture, and how much the bone has gone for avascular necrosis or not. But the bone scan, MRI is explaining everything, but the bone scan is telling there is an inflammation happening, there is some fracture or some reaction happening, but it is not telling how big is the fracture, what is the anatomy of the fracture line, is there an avascular necrosis happening or not. So both MRI and bone scan can be a potential investigation option for an occult scaphoid fracture, or for that matter, any occult fracture in the body. But MRI is always much more sensitive and specific than a bone scan when to diagnose an occult fracture. Clear, guys? Several questions from scaphoid can be asked, and one such potential question could be this. Now, you all know scaphoid can also be tested in other ways. For example, can you see the second image in this? The second image is again a T1 weighted image. In a T1 weighted image, a necrosed bone will look dark. A necrosed bone would look dark. But in an X-ray, and a CT, X-ray and a CT, the dead bone will look white. Dead bone will look white. In a T1 weighted MRI, dead bone will look dark. Dead bone dark, because normal bone is white. Dead bone look dark. Normal bone is white. Right? And you all know the vascular anatomy of scaphoid. The scaphoid is receiving dorsal flow, and the flow is always from the distal to proximal. Which means the blood flow comes like this, goes up like that, and then comes down back like that, like a U-turn. So it goes from distal to proximal. So whenever there is a fracture happening at the waist, or whenever there is a fracture happening at the proximal part of the scaphoid, the proximal pole goes for necrosis. Okay, if the fracture is happening at the distal most, for example, this part. Okay, if the fracture is happening at the distal most, for example, I'll show you. If the fracture is happening at the distal most, for example, here, then that is not compromising any big flow of the scaphoid. So waist fracture and proximal proximal pole fractures can cause avascular necrosis of proximal pole. And a dead bone, any avascular bone, would look white in an X-ray and a CT. In an X-ray and CT, osteomyelitic sequestrum look white because it is dead. Clear? Several potential questions from these images. Do you all agree? So whenever you are seeing one image, you can learn several points from one single image. Do you all agree? Shall we go to the next slide? And this is what your AIMS and the JIPMO want you to, this is how they want you to think. This is how they want you to think. Now tell me, what is the first image? The first image in this, is it an MRI or CT? The first image is MRI or CT? In the chat box, you can either write M or C. It is an MRI. It is an MRI. Okay. So sometimes they can test like this. Very simple, right? And now the question is diagnosing discitis. Although the word discitis means inflammation, what they are trying to say is it is an early stage of vertebral osteomyelitis. Okay, if I ask the question, which is the most sensitive test for osteomyelitis, then the answer, which is the gold standard culture, which is the most sensitive radiological investigation of choice for an osteomyelitis, then the answer is MRI. But everyone has tested the topic. So instead of telling the word osteomyelitis, if I use the word, the most sensitive test for diagnosing a vertebral osteomyelitis, instead of using the word osteomyelitis, if I say discitis, which is an early version of vertebral osteomyelitis, because When a disc is going for inflammation and infection, it will immediately spread to the bone, and it is going to become a vertebral osteomyelitis, right? So, which is a best sensitive parameter test to assess the vertebral osteomyelitis or discitis? Then the answer is again MRI. But, sometimes by the word discitis, they may confuse us. Okay, I have given few other investigation, bone scan and also gallium. If at all the option MRI is not there, okay, and the option has bone scan or gallium scan, then the answer should be gallium scan. Because you look into the pictures, you can see the bone scan. In a bone scan, you can see some changes. But when you are loading the bone scan with the gallium isotope, you can see the extent of osteomyelitis much better than a regular technetium bone scan. Can you all appreciate that? So if the option doesn't have an MRI, then you should think about, when the question is about vertebral osteomyelitis, then you should think about bone scan. And in the option, if they are specifically has given a gallium scan, then you should think of gallium scan than a regular technetium bone scan. Yes? Yes. See, it is all commonly tested topic, but we are going slightly deeper. That's it. I don't want to ask any fascinating question here. I want to test a commonly tested questions, commonly tested topic, but an uncommonly asked questions. That's it. Clear? Shall we go to the next topic? Try to answer this question. Chiralgia paresthetica. You all know the word mera means thigh. Okay. Why, the super specialty MCH? What does the MCH means? The word CH means chiralgia. MCH, right? In which the CH means chiralgia. So the word chiralgia means hand. Surgeons uses hand, right? The master of hand. That's why they say MCH, master of hand, because they uses the hand. Okay. Chiralgia means, chira means hand, algia means pain, paresthetica, altered pain sensation in the hand is chiralgia paresthetica. So which now definitely, I didn't make this question confusing because I could have given an easy lower limb nerves, but I didn't use the word. Everything, whatever the options I have given are nerves of the upper limb. Ulnar nerve at the Guyenne canal, which is also called as an ulnar tunnel syndrome. Ulnar tunnel syndrome, that is totally different. Okay. Median nerve is affected in a carpal tunnel syndrome. Okay. Anterior interosseous nerve can be affected, maybe in the supracondylar fracture can cause an anterior interosseous nerve, or several other pronator syndrome can affect a median nerve and an anterior interosseous nerve. But a chiralgia paresthetica, also called as a Wartenberg syndrome, also called as a wristband syndrome or a wrist watch syndrome, is because of a superficial, because see, the wristband is going to compress only a superficial structure. It is not a carpal tunnel. This is not a carpal tunnel syndrome to start something from deep inside. It is the compression from the superficial structure, wristband. So superficial nerves are affected. Which nerve is affected? Superficial branch of the radial nerve. This is an exact picture where you should test a tinal nerve, a tinal sign. This picture is from the 1993, if I'm not wrong, when they first published chiralgia paresthetica. So this is like a big list that you may need to know. Carpal tunnel, median nerve, pronator syndrome, median nerve, Kilonevin syndrome, anterior interosseous nerve, ulnar tunnel, which means Guyenne canal here. Okay. Superficial ulnar nerve, cubital tunnel, cubital foci is in the front, cubital tunnel is at the back, cubital tunnel is here, which is at the medial epicondyle. So the nerve is ulnar nerve. Thoracic outlet syndrome, you should know. The cervical rib affects more common women, and the tests are Adson test, wrist test, Roos test. Please type in internet, what is Adson test, what is wrist test, what is Roos test, because few times they can just explain a test and ask you, what is this test? Or they can just ask a picture and ask, what is this test? Okay, tarsal tunnel syndrome. You all know carpal tunnel syndrome. There is something called tarsal tunnel syndrome, which is posterior tibial nerve, and meralgia paresthetica, long cutaneous nerve of thigh, right? And this is a recorded video, so you can come back to this slide anytime and then make a copy. Okay. So I have given few other things like a jogger's foot, Baxter nerve, anterior tarsal tunnel syndrome, popliteal artery entrapment, iliotibial band syndrome, In order to assess an iliotibial band, what test you will be doing? Ober test. While if you want to assess a rectus femoris, then what test will you be doing? Elie-Duncan's test. So all these tests can be potential questions. Okay, all these tests can be potential questions. Piriformis syndrome, sciatic nerve can be affected, and the patient cannot do a flexion, adduction, and internal rotation. Okay, Fader test is positive. So these are all a potential common compressive neuropathy, which they can ask as a question. Try to answer this question. What is the most common sarcoma of the hand? Guys, please give utmost attention. Please give it utmost attention. I could have made the same question slightly confusing if I have put another option called squamous cell carcinoma. So answer this question. A, B, C, D, E. What is the correct answer? You are answering now. A, E. Think. Mohan, just because I have given option E, you got immediately confused. That is a problem. That is a problem. The question clearly asked, which is the most common sarcoma? What is the option I have added last? Most common squamous cell carcinoma. What is the difference between a sarcoma and carcinoma? If it is from an epithelial origin, okay, then it is carcinoma. If it is from a mesenchymal origin, then it is sarcoma, right? So the squamous cell is a carcinoma, sir. The question asked is most common sarcoma. This is what exactly. Mohan, don't feel sorry. This is what will exactly happen in an exam hall. You will just miss one letter or one word, and then you will get the options wrong. Okay, don't feel sorry. This is how they are making the same questions. Like in the next slide, you will understand. Okay, in the next slide, you will understand. For this question, the answer is epithelioid sarcoma. Epithelioid sarcoma. It is not epithelial sarcoma. It is not epithelial. Epithelioid sarcoma. Okay, which means a mesenchymal cell origin, which looks like an epithelial carcinoma. Okay, it looks like a squamous cell carcinoma. Are you seeing this picture? Isn't it looking like a squamous cell carcinoma? But it is not squamous cell carcinoma. It is an epithelioid sarcoma. And the next picture, what I have shown, is synovial sarcoma. Is synovial sarcoma. Remember, both epithelioid and synovial sarcoma can happen in hand, and they are the more common kind of sarcomas in the hand. Okay, and they most commonly go to lung. Any sarcoma is a vascular metastasis. Any sarcoma is a vascular metastasis. But remember, which is a sarcoma which can go for a lymph node metastasis? Epithelioid and synovial sarcoma, a dermatomyosarcoma, or a leiomyosarcoma. All these sarcoma goes through blood vessels, right? All these sarcomas go through blood vessels. They will never go to the node. But sarcoma which can go to a node, carcinoma goes to the node, sarcoma goes to the vessels. Sarcoma which can goes to the node is synovial sarcoma. So next only to lung, the second most common metastasis is to the lymph node. These are all the potential questions which I can ask from a commonly tested simple topic. Okay, now try to answer all these 4 questions. Now, Mohan Raj, I am expecting answer from you. Which is the most common malignancy of the hand? See, if you see all these 4 questions, only I have changed 1 or 2 words in between. But the answer is going to be entirely different. Answer, which is the most common malignancy of the hand? Cell carcinoma. Very good. Squamous cell carcinoma. Which is the most common malignancy of a hand bone? Hand bone. Malignancy, not a sarcoma. Answer, Mohan. Easy, right? Asked wrong answer. The most common malignancy of a hand bone is metastasis. Usually from lung. If I asked the word most common primary malignancy of hand bone, then the answer. Mohan, answer. Mohan, I'm not insulting you, man. I'm just trying to create a conversation with you. Thereby, I feel as though I'm exactly sitting in a class and talking with you guys. Only you are responding, that's all. Answer, Mohan. Most common primary malignancy of hand bone. Then you can think about chondrosarcoma, sarcoma. Now, okay, common malignancy of a hand bone. Oh, sorry. Yeah, okay. Hand bone. That was the last word. Okay. Most common sarcoma of the hand. Then the answer is not the hand bone, just the hand. Then the answer is epithelioid. Epithelioid sarcoma. Okay. Most common primary hand bone is chondrosarcoma and osteosarcoma. Okay. Clear? Am I making sense, guys? Only one word difference, but it can make the entire answers different. Enchondroma. Someone was telling Pravantika, enchondroma is not a malignancy at all. It is neither a sarcoma at all. Agree? Pravantika? It is benign tumor. Benign tumor. Very good. Very good. See, if I'm uttering your names, it is not to insult you guys. It is I'm just trying to get a personal connections. That's it. Okay. Now, again from a bone tumor, if they are asking this question, this is how a person with a multiple metastasis into the bone will look. And you all know the most common skeletal malignancy is a metastasis. The most common skeletal malignancy is metastasis. Which are the three most common primary tumor to metastasis to bone? Now, remember, if they are asking you a question, which is the most common malignancy to metastasis to bone? Breast. This is like a recent update, guys. Recent update. I'm telling you, which is the most common malignancy to metastasis to bone? Breast. Next only to breast, prostate. Next only to prostate, lung. Okay, this is the order. This is the order. Breast, prostate, and lung. Breast, prostate, and lung. This is the order. Only if the option doesn't have a breast or prostate, then you can think about lung. Okay, but otherwise, in a female, it is breast. In a male, it is prostate. Even if they are not mentioning male or female, then the answer is still be breast. Clear? Breast is the most common primary tumor to metastasize to bone. For how many of you this is a new point? This is like a very recent things, man. Okay. Now try to answer this question. The same metastasis, but I'm asking a still more deeper question. You see, this is how I'm not just going to talk about orthopedics. What I'm trying to tell you is INICET exam is not a tough exam. Okay. You are just going to study whatever you studied for All India, but make it more concept driven and go a little more deeper. That's it. If they are telling a CT-based biopsy, then look into the image of CT-based biopsy, because that can be a potential question. They can just display what is happening, right? So the question, this patient is coming to you with a neoplastic lesion at a L2. All other metastatic workup, everything has got done and everything is negative. So histology reveals that the patient is history reveals the patient is getting treated for a breast cancer. As I said, breast cancer, most common. It can go for skeletal metastasis. So what is the next step? Will you do a biopsy? Will you do a vertebroplasty? Vertebroplasty you will do when the patient is having a pathological fracture because of an osteoporosis and as a pain management. Is it a definitive treatment? No way. Is it like a first line of management? No way, man. You have to diagnose why this is happening, right? Of course, you can start a radiation therapy, but that is a treatment option, but you got to confirm your diagnosis. So the treatment management is CT-guided biopsy, Mohan Raj. So the question answer is easy, but what I am trying to explain you is how would a CT-guided biopsy image would look? And when they are trying to do a CT-guided biopsy, how can you see in this image? So they will use like this. They will put one hole. Through the one hole, if they are not reaching, they got to make another hole Like they got to go 1 centimeter or 2 centimeter or 3 centimeter, and it is with eyeballing. Doing that 1 centimeter or 2 centimeter is hard. So they will use this graduated scale like thing in which, oh, if I go to this hole, I'm still not able to touch the tumor. Okay, let me put in this one, this one, this one, this one. So sometimes they can just display this picture and ask like, what is the procedure being done? See? So just for the sake, I have to explain those things. Now, again, another easy topic, easy, commonly tested topic, which is osteosarcoma, right? But the question, look into the question. Which of the following tumor has the most favorable prognosis? Which of the following tumor has the most favorable prognosis? Just make a guess, wild guess. You all, the first thing you would rule out is an osteosarcoma, right? And then an Ewing tumor. Predominantly, everyone would go for either a chondrosarcoma, because that is like a less known topic. We all know Ewing sarcoma is having like a very bad prognosis simply because it mimics like an osteomyelitis. So you will diagnose it late. So it is a bad prognosis. And invariably, we all know osteosarcoma is bad. So we all think chondrosarcoma, but the word, look into the word, man, the first letter, first word, de-differentiated, which means undifferentiated chondrosarcoma, which means a very bad chondrosarcoma is going to have a bad prognosis. So among this four, which is carrying a most favorable prognosis, the most favorable prognosis among this four is a perosteal osteosarcoma. So osteosarcoma is multiple time tested, but I'm going little deeper. That is perosteal osteosarcoma. What are all the things that you should know about perosteal osteosarcoma? All osteosarcoma are male predominant disease, right? But perosteal is female predominant disease. So it affects female. And as regular with osteosarcoma, perosteal osteosarcoma again affects femur, but especially posterior cortex of the femur. Posterior cortex of the femur. And many people would say it is, I mean, osteosarcoma is bad prognosis, but perosteal osteosarcoma is good prognosis. Not good in a sense like, oh, you will have absolute recovery, but much, much better recovery than a regular osteosarcoma. That's why I just dimmed the image. Good. It is good. Good to an enough that it is better than an osteosarcoma, regular osteosarcoma, but not like a regular, a regular enchondroma. Okay, so it is good, much better prognosis than a regular osteosarcoma. Getting that point? Getting that point? Now, so the low-grade tumors are a perosteal osteosarcoma, an adamantinoma, well-differentiated osteosarcoma, grade 1 chondrosarcoma in patients with multiple hereditary exostosis, chordoma. All these, no. Chordoma is not a low grade. This is high grade, sorry. Chordoma is high grade. Chordoma is high grade. Now, Ewing's is very commonly tested topic. Guys, it is needless for me to say osteoclastoma is the most important topic among all bone tumor. Okay. So I believe that you will read osteoclastoma or the giant cell tumor. But other than that, other commonly tested topics are osteosarcoma, Ewing sarcoma, and they can go a little bit deeper. So the question I asked here is an Ewing sarcoma. What is the cytogenetic abnormality? You all know Ewing is having an onion skin appearance, which means delaminating periosteal reaction. And it can present like an osteomyelitis. It is a small blue cell tumor. Which means it is a component of a PNET tumor. Primitive neuroectodermal tumor. It is, but the question asked is a cytogenetic abnormality. Trisomy 21 is Downs. XO is Turner. XXY is Klinefelter. Right? So the answer is translocation 1122. 1122. Is there any trisomy associated? with the Ewing sarcoma, yes, trisomy 8 bar 12, trisomy 8 12 can be associated with an Ewing sarcoma, but not trisomy 21, Guys, the whole agenda of this question paper is to make you realize we can frame it off questions from an easy topics. Are you all getting that? That is the whole point of this session. I can ask, these cells are glycogen-rich cells, right? Instead of asking which is a stain you will use for to stain a glycogen in a pathology slide, I can ask a question, which of the bone tumor can show PAS stain positive? And I can put Ewing as an option. Then the answer would go for Ewing sarcoma. Are you getting, guys? It is a glycogen positive tumor, right? Glycogen positive tumor. What does a glycogen positive tumor means? A stain, right? So I can ask which of the following tumor can stain positive with a CAS stain? Yes, am I right? That stain. So I can integrate a pathology question to a bone tumor and then ask you, assess you on your pathology knowledge of which stain is going to stain for glycogen. This is how exactly INICET they will frame. So whatever the topic you are reading, go slightly deeper and clear one more layer. That's it. Just one more layer or two more layers. Just see the images. That's all. Now, what is this question? Try to answer another bone tumor questions. Why several bone tumor questions? Because invariably there will be one fracture question, one bone tumor question. I'm expecting either one reactive, like compressive neuropathy kind of, or osteomyelitis related questions. These are all common, standard. So you all know among this question, which is having a greatest risk for developing a bone sarcoma? Yes, Pravantika. Right, you are right. Remember, enchondroma is having chance around like 5%. Osteochondroma, if it is a regular osteochondroma, 1%. If it is a multiple hereditary exostosis, as in this condition, multiple osteochondroma, EXT1 gene positive. If it is a multiple hereditary exostosis, as in this image, then you are having 5 to 10% chance. There is another condition called Olier's disease. What is Olier's disease? What is Maffucci syndrome? Both are multiple enchondroma. Both are multiple enchondroma. But Maffucci has hemangioma in it. So Maffucci is having 100% chance for malignancy, but Olier's disease is having only 30% chance for malignancy. So Maffucci is having 100% chance for malignancy. Maffucci is having 100% chance for malignancy. Okay, so this is how a Maffucci would look, or even Olier's would look. And this is how the X-ray would look. But remember, 100% chance, Maffucci is having 100% chance for malignancy. Look into this question and try to answer. A, B, C, D. Common topic, but I'll ask a few uncommon questions in it. The common topic and the common question, right? So the answer is D. We all know Paget's, the problem is with the osteoclast. But the question now, what is this appearance? Can you all see this skull? What is this appearance called as? You all know cotton wool spots. You all know blade of grass appearance. That is this picture. You all know picture frame vertebra. You all know ivory vertebra. You all know banana fracture. which is a pathological fracture with Paget's. And you all know the most common bone is pelvis. And you all know the 3 stages, that is osteolytic stage, followed by mixed stage, followed by osteosclerotic stage. And this is happening with a lot more blood flow coming into the picture. So most common cause of death is a cardiovascular arrest. But other problems, it can become a malignancy. You all know all that. My question is, what is this appearance? The appearance is called, can you all see this cap? Can you all see that cap? This type of cap is called as Tom O. Shanter cap. Tom O. Shanter cap. This is Tom O. Shanter appearance. Tom O. Shanter appearance. Can you see that cap like Tom O. Shanter appearance? So we all go for the common topics. We all test the common things, but we may ask a question, an uncommon question from a common topic. Like one more lady. Are you getting this question? How many of you are enjoying this class? How many of you are not liking the class? You want me to be fast or slow? Just let me know there. I'm just going by your chat box. If you respond, I'll go more faster or slower. I just need your approval. Right. No response. Guys, are you scared of me? Come on, guys. Which of the following laboratory studies is most likely to yield abnormal results in patients with Paget's? Serum protein electrophoresis. This is to assess multiple myeloma. C-reactive protein ESR. This is to assess inflammatory arthritis. Definitely will be elevated even in Paget's, but that is not a most likely thing. Serum prostatic antigen. This is for assessing prostate cancer and metastasis. Serum alkaline phosphatase is the only thing which is a bone marking parameter among all these 4, only thing. So this is an easy question. This is a very easy question. But you should understand, Paget's is not only a bone forming condition, because serum alkaline phosphatase indicates there is an active bone formation happening. So it is not only a bone forming condition, rather it is also a bone destroying condition. So it is not only positive for alkaline phosphatase, but also positive for acid phosphatase. That way, you can also see a hydroxylysine or hydroxyproline in urine, because it is bone forming and the bone destroying. Yes, it can be anything. Like even if with the normal serum alkaline phosphatase, you can still have Paget's. But most often, serum alkaline phosphatase is elevated. Now, the next question. Which of the following is an incomplete spinal cord injury syndrome? And among the incomplete spinal cord syndrome, which is having the worst prognosis? This is a slightly modified version, you know. Most often they check bulbocavernous reflex. But now, once a person comes to you with a traumatic spine injury, and once the patient has recovered from a spinal shock, and you will going to classify the patient into complete spinal cord injury or incomplete spinal cord injury. And there are 4 types of incomplete spinal cord injury. One is central, other is posterior, other is anterior, and other is Brown-Sequard. My question is, among these 4, which is the worst prognosis? People thinking Brown-Sequard. You know why? Why people are thinking Brown-Sequard? Among these 4, the only thing you know is Brown-Sequard. Yes or no? That is an important 5-mark question in UG. 5-mark question, right? Right? Yes or no? Let me tell you, the most common incomplete spinal cord injury, most common, is central cord syndrome. Best prognosis is central cord syndrome. Second most common is anterior cord syndrome. Second most common is anterior cord syndrome and carrying worst prognosis. You all know a central cord syndrome is having dissociative weakness, which means upper limb is more affected than lower limb. And anterior cord syndrome is a damage to spinothalamic tract. So pain and temperature is predominantly affected and it is not going to recover. It is not going to recover. Posterior cord syndrome is among all, the rarest is posterior cord syndrome. The rarest is posterior cord syndrome. Brown-Séquard cord syndrome, most common with trauma, penetrating trauma. Most common with penetrating trauma. Penetrating trauma. And it is also having better prognosis than anterior cord syndrome. Okay, among all, the worst is anterior cord syndrome. Anterior cord syndrome. Clear? So they are usually assess Babinski reflex. Babinski reflex is S2 to S4 reflex, which marks the end of the spinal shock. 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 And you are, to assess a Babinski reflex, you are going to pull the penis or glans penis, or you're going to pull the Foley catheter and look into the anal orifice. Anal orifice. You are not looking for any response in the genital. You are going to look for the anal orifice. Okay. And the response is mediated through S2 to S4. Clear? Clear? Shall we go to the next question? Again, very commonly tested topic, open injury. Open injury. The question asked is, external fixation is used most often for which of the following? Definitive treatment for a grade 1 is external fixator. Do you think a person is coming to you and you're going to put a fixator like this as in the second picture and say, you're going to live with this? No. You're going to live with this until the fracture unites. No way, man. External fixation is only a temporary fixation. So I made the option easy. I made the option easy. Thereby you will all feel motivated to get into the, but I can slightly twist the option and make the same question tough. Okay. For grade 1 open tibia fracture, what is grade 1? What grade am I talking about? Costello-Anderson grade. GUS, Costello-Anderson grade. So Costello-Anderson grade, what is 1? Grade 1 means less than 1 centimeter wound, as in this case. For that case, you can do definitive management, just wash and do a definitive management, but not with an external fixator. Put a nail and finish it, man. You can directly go for an internal fixation in a grade 1 Costello-Anderson. You don't need an external fixator at all for Costello-Anderson type 1, unless it could be if it is from a farmyard injury or it is from a gunshot injury or something like that. Okay, otherwise you don't need a external fixator for a grade 1. Okay. Definitive treatment for pediatric femur fracture. Pediatric femur fracture, the treatment, definitive treatment is tense nail. Only for an open fracture with the soft tissue compromise, as a temporary treatment, you are going to use external fixator. Unstable elbow injuries, then you are going not for external, you are going to find which ligament is problem and you are going to go and fix with an anchors. Easy. Okay. Okay. So the answer is C. The answer is C. Mohanraj, correct. I made it a bit easy. Now, since I used the word unstable elbow in the previous topic, I'm asking this question. What 3 injuries make up the terrible triad of elbow? Do you remember while taking class, I used this topic? And I said terrible triad of elbow is also called as terrible triad of Hotchkiss. can see an elbow dislocation. You can see an elbow dislocation, and you can see a radial head fracture, and you can see a coronoid fracture. Okay, so there will be a radial coronoid fracture, radial head fracture, and lateral collateral ligament fracture because dislocation, and it causes dislocation. So answer is the coronoid, radial head, and collateral ligament injury. Okay. Easy. Easy. Shall we go for what is the terrible triad of knee? Terrible triad of knee. Terrible triad of knee is ACL injury, medial collateral ligament, and the medial meniscus. Terrible triad of knee. Okay, terrible triad knee. ACL, medial collateral, and medial meniscus injury. Perfect, Pravantika. You know the answer. Sorry, just a repeat question. Now, since we spoke something about Ewing sarcoma, and while talking about Ewing sarcoma, I told it is having bad prognosis, especially it can sometimes behave like an osteomyelitis. My next question is, if there is an osteomyelitis in a arthroplasty patient, what is the diagnosis? Diagnosis, guys. Pravantika, you are right. Mohan, you are right. So whenever there is a word osteomyelitis comes in ortho, osteomyelitis comes in ortho, they always use the most common organism is Staph aureus. But an infection as low as this in this case of a joint arthroplasty, okay, you are not seeing any golden colonies, right? You are not seeing any golden colonies. You are not seeing any golden pus. Okay, it is a slow growing organism. It is a slow growing organism, and that organism is growing around the prosthesis, forming a biofilm, and it wants to escape the virulent mechanism of the blood, so of the body. So it tries to stay close to the metal. So such a virulent organism which want to escape the body virulent mechanism and staying close to the prosthesis is coagulase negative staphylococcus, which is Staphylococcus epidermidis. Most they ask, right, coagulase positive, why coagulase negative, all those questions, maybe to assess all this. Okay, so the answer for this is Staphylococcus epidermidis. Now, answer this question. So osteomyelitis, again, a common question. See, of late, I can see they have stopped asking questions about whether you need THR or TKR, what is THR, what is TKR, what is hemiarthroplasty. Those kinds of questions have started coming down because it is getting so rampant in orthopedic practice that everyone is knowing. Now they can ask bit questions. I know, like 3 years back, they asked a question about a patellar notching. Patellar notching, I'm telling you, patellar clunk syndrome. I'm telling you, even if you ask a first year orthopedic guy, they may not be answering what is patellar clunk syndrome. Such a tough question, but sometimes they ask. Okay, so I'm asking one such question: what is the most frequent complication following a primary total hip arthroplasty? Total hip arthroplasty. Infection, less chance, 2 to 5%. Dislocation, 2%. Metal hypersensitivity, 2%. Thromboembolic disease is much more common than 2%. Okay, so I'm telling you, when you are putting a femur implant, right, the femoral stem, the fat is getting pressurized, and that will release chylomicron into the blood flow. The person can develop a fat embolism syndrome at the 4th day after surgery, and patients would die. Okay, so invariably after a total hip replacement, most common in most of the corporate hospital and across Sydney in Australia, everyone invariably they will put the patient on blood thinners. Okay, they will put the patient on blood thinners. And now another common, easily picked topic, very commonly asked topic, but slightly with a better explanation, I'm trying to put the same question. So this question is about plantar fasciitis. And the person has tried NSAIDs and it is not helping. So what else we will try? Okay, so when I'm giving NSAIDs, if the NSAIDs are not working, then I will give some inserts and then I will do some stretching exercises. Just for your sake, just for your practice, I'm telling you what kind of exercises. Put a pillow or something like that and ask the person to curl, hold the pillow by curling the foot. Okay, that is a plantar fascia stretching exercise. Ask the person to put the foot closer to the wall and ask him to bend, thereby the knee should touch the wall. Okay, the knee should touch the wall. So that is the second. Okay, these are all stretching exercises. Just a second, I think I need some charge. Okay, the question also asks you to put a corticosteroid injection. You can put, but only after this. Even then, I would think you need to be cautious. Why? Because corticosteroid causes thinning. So once if there is a thinning of the tendon, then it can cause rupture of the fascia. It can cause rupture of the fascia, plantar fascia, or the tear of plantar fascia. So that is a problem with the steroid injection. So I will do NSAID, I will do stretching exercise only if everything, even now, to be honest, I would then try an extracorporeal. So after this, I would try an ultrasound, because although it is not very greatly helpful, it is still better than steroid. And then I will try to do PRP injection. If nothing is helpful, then I will go for steroids. And even with steroid, if it is not helpful, then I will go for surgery. Can you see the inflammation here? This is a T2 imaging. T2 imaging. Can you see the spur here? And can you see the inflammation here? Okay, that is the calcaneal spur and the inflammation. Calcaneal spur and the inflammation. Have you any time, any of you in this session, have you any time seen an MRI of a plantar fascia? Or this is the first time? Just say yes or no. Single letter. First time. Now, I think we are coming to the end. Okay. Whenever there is a Bennett fracture, you all know Bennett fracture. You all know Bennett fracture. Bennett fracture is the base of the first metacarpal. But in Bennett fracture, what makes it works? What makes the reduction of the dislocation and reduction of the fracture difficult? Which tendon? Abductor pollicis longus. Abductor pollicis longus. So whenever there is a Bennett fracture, if you're telling, oh, I will just put a POP and then I'll correct you, very, very difficult, because the intact abductor pollicis longus would pull the bone, So I would pull the bone and then stabilize the fracture and put a K wire and put a K wire and put a K wire. So Bennett fracture means first metacarpophalangeal fracture, base fracture. Such questions are obsolete. No one is asking such questions. No one is asking such questions. These questions has gone obsolete. Settu podanja questions, we call them. Okay. You should know, if at all there is a Bennett fracture, why the reduction is not possible. Okay. Now, this is an anesthesia question. But brachial plexus. right? Very common orthopedic topic. What is the level of brachial plexus? And I mean, like in the neck, where in between which two muscles? It is an interscalene block will block the brachial plexus, right? So the answer is that this is an anesthesia question, but how an anesthesia question can, I'm just trying to make up for ortho. So a scalenus anterior and posterior in the interscalene groove, we will see the traffic light appearance, and in between, if you go, you will release the drug. So basically, this is an anesthesia question, but assessing the anatomy and all your orthopedic knowledge about the location of brachial plexus. Clear? That's what your PGI or your this INICET exams is not just going to restrict them itself into one subject. They want to make a question which can test through 2 or 3 subjects, your anatomy, your ortho, your anesthesia. You see? So that's how they frame the questions. And this is another easy question. Gout. Many people would have, you may know, gout is a problem of the first metatarsophalangeal joint. You know the negatively birefringent. I don't know how many of you have seen this microscope image in the polarized scan, but I have never seen a gout crystal in gross anatomy. Only after coming to Australia, I saw a few patients with the gout crystals, and this is how it will look during your surgery. Okay, this is how, like a tiny dot, white dots. This is how it will look. Okay, like a tiny white dots. Just to show it up, I put that. And so what I will be seeing, I made the question. I made the question easy for you. It is a negatively birefringent monosodium urate crystal. Easy question. But I can just display one picture and ask, what crystal do you think it could be? Or I can display this picture and ask you, what do you think could be the potential disease? So common topic, gout, but I can make the question tough by just putting one image and asking a question based on it. Okay, easy. Next question is about tennis elbow. Okay, so whenever there is a lateral epicondylitis, okay, you all know it is tennis elbow, right? But the question asked is not tennis elbow. The question asked is not like extensor origin. They asked which one muscle. So now you know it is either B or D, which is the answer. ECRB. ECRB. Just one more level. That's it. Mohan Raj, you made it right. So the answer is extensor carpi radialis brevis. And remember, lateral epicondylitis, tennis elbow is not an inflammatory condition, despite it is finishing with the word itis. It is non-inflammatory condition. Which means there won't be any inflammatory cell in pathology. And what is this test? Cosen test. What is Cosen test? That is Cosen test. What is Mills test? Stretch and then ask the person whether they are having pain. That is Mill test. Okay, next only to extensor carpi radialis brevis, the second most common muscle to be involved in tennis elbow is extensor digitorum communis. Extensor digitorum communis. That is the second only most common muscle. Okay, what is a test to assess extensor digitorum communis? Any response? The answer is the answer is, what is the answer? MAUDSLEY, Maudsley's test. The answer is Maudsley's test. Maudsley's test. Okay, because here they are not assessing the extension of the wrist, rather they are assessing the extension of the fingers. So that is called as Maudsley's test. I'm dyslexic. I don't know how to pronounce this test. So I just had a small note outside there. So Maudsley's test. Maudsley's test, which is assessing extensor digitorum involvement. So that is how I'm going to differentiate whether extensor carpi radialis brevis is involved or is it extensor digitorum communis. That's it, guys. So we discussed 30 questions. Hope I think we took 2 hours, right? 30 questions. So understand PG preparation, especially when it comes to INICET, is not that easy that you have to go one level higher. But it is potentially easy because they are going to test only the same topics, but they are going to test slightly deeper. So they give more importance to the previous year question papers, but don't just repeat doing the questions, but rather give more importance to the explanation. I think there is a very high chance for you to get a good score. Do you have any questions, guys? Otherwise, we can finish the session. Any questions, feedback, comments, please? Raj, happy man? Vishal, Mohan, Raju. Okay, perfect. Okay, thank you. Please let me know your feedback. We can improvise on it. If you don't understand any topic, just feel free to ask me. I can help you. My number is 984-0434-889. That's 9-1. I still maintain my Indian WhatsApp number, so please text me. We'll have a catch up. Okay. Thank you, guys. Bye.